have Dr. Uday Chankhede, and the topic is uro-oncology and robotic surgeries in uro-oncology. And the chairpersons are Dr. Gajanan Dumbre sir, family physician practicing in ONS since 32 years, and Dr. Neelam Kadam ma'am, anesthetologist with 15 years of experience in critical care and administration, presently working as a medical director at Sanjeevani Medipoint Hospital, Ondh. We welcome you, sir and ma'am. Can we have the speaker on the dais, Dr. Uday Chankhede, sir?
Hospital, Pune, fellow uro-oncology and robotic surgery at Tata Memorial Hospital, Mumbai. Uro-oncological cancers, prostate, kidney, urinary bladder, penile and testicular cancer, minimally invasive surgeries, laparoscopy and robotics. I request Dr. Chandan Khede to start lecture.
Good afternoon, everyone. Greetings from Urokul Hospitals. I thank BMA Association for giving me this opportunity for a lecture. I am Dr. Uday Chandan Khede, practicing consultant uro-oncologist in Baner, Urokul Hospital. So basically we are having a workshop, right now it's going on. So it's an International Society Reconstructive Urology workshop where we are conducting a live operative workshop. And almost 25 surgeries has been over live operative surgeries, which are basically reconstructive and robotic surgeries. So this is the agenda of my presentation today. Basically, I am just going to discuss what basically is a uro-oncology and role of robotic surgery in uro-oncology. So before we dive into uro-oncology and some sort of questionnaires, so one should know what is uro-oncology. Uro-oncology basically, it's a subspecialty branch of urology or subspecialty branch of oncology, where they focus mainly on urinary cancers and male reproductive cancers. And the person who specialized in this is called as an uro-oncologist. So the cancer which it's included in this fields are the cancer which are included in this field are basically the first common cancer which is seen in male is the prostate cancer. Second one is the kidney cancer, the urinary bladder cancer, and the rare cancers that is penile, testicular, and adrenal cancers. So whenever we discuss about oncology, these are the common sort of questionnaires. It comes into the mind how common these cancers are. Second, whether if this is common, are they curable? If they are curable, then what are the early signs and symptoms when we should expect this could be a cancer? If person is diagnosed with this kind of cancer, whether it's feasible to preserve an organ, we can, like for example, if it's diagnosed with the kidney can be preserved or not. Second, penile cancer, whether penis can be preserved or not. Whether a bladder cancer, do we need to remove a complete bladder or a part of bladder? Or if we are preserving, whether it can be done with a minimal invasive technique. First, that could be a laparoscopy, or second could be a robotic surgery. So the first question, how common these cancers are? So basically, these are very, very common cancers. So if we go through the global cancer registry, the prostate cancer is the second most common cancer in the males, followed by a urinary bladder cancer, kidney cancer, then penile and testicular cancer. Second, whether it's a curable? Yes, most of the cancer are curable if they are detected in the initial stages or the lower grades. And if the cancer are detected in the higher stage or metastatic stage, the best part of the uro-oncological cancer is that with the help of multiple modalities like medical oncologists, inclusion of radiation oncologists, the palliative care can be improved and signs and symptoms can be reduced. Lifespan is prolonged in this kind of cancers. How to diagnose this cancer at early stage? Coming to the practical scenario, most of these cancers are silent at initial presentation. They don't have any signs and symptoms. For example, Most of the kidney cancer at early stage, they don't present with any kind of symptoms. Second, prostate cancer, they don't have any symptoms. Mostly they are detected in a screening program or routine health checkup. For example, kidney cancer is now been commonly detected if person gets an ultrasound for some other reasons. A small renal mass can be detected on the ultrasound. Secondly, this patient may sometimes or some kinds of urinary symptoms would be present. Like Dr. Anand Dharaskar has already mentioned some kinds of lower urinary tract symptoms. This could be range from any increased frequency, person passing urine frequently, urgency. That could be a kind of some hint that you may be suffering some kind of urinary tract cancers. And some cancers are but obvious that passing blood in a urine, that could be a presentation of a bladder cancer, upper tract kidney cancer. And the other cancers like penile cancer would be but obvious. There would be some kind of lesion or mass or ulcer on the penile skin, or there could be some kind of slowly growing hard mass on the scrotum which is painless in condition. And kidney cancer generally on late stages they present with like bony pain with or loss of appetite, weight loss. The early cancers are mostly silent. So I would say patient should be undergoing a patient or normal routine, and even doctors should undergo a routine health checkup, and where the ultrasound should be a mandatory, and any person with an age more than 60 years should undergo a PSA screening test. So now, organ preservation is the most common scenario. Whenever the patient comes to us, the first question comes to our mind whether kidney can be preserved or not. Yes, there is a possibility if the cancer is diagnosed at early stage. Now, again, the indications has been extended, like any cancer, kidney mass more than 7 centimeters and up to 10 centimeters, the kidney preservation is possible. So whether this preservation surgeries which are being done, can be done with minimally invasive approach? Yes. The commonly used approach is, all we know is laparoscopy. Now with the help of newer technology like robotic surgery has come into picture, the morbidity, hospital stay, infection rate, shorter hospital stay, this can be achieved with the help of a robotic surgery. So radical nephrectomy can be an easy job or a piece of cake with the help of a laparoscopy, but preserving a kidney like a partial nephrectomy or removing a prostate, you need a better equipment and better device. So that can be possible with the help of robotic surgery. So I am commonly using a Da Vinci robot, and I will just dive into what exactly the Da Vinci robot is and how Da Vinci robot is works basically. So it has three components. First is the surgical console. I will just show the picture. Second is the robotic arms. Third is the high definition 3D vision card. So in this picture, you can see on the left side, basically it's a patient card. It is a robotic arm, patient surgeons which operate with the help of this arm. And second is the vision card, where the assistant sees and helps the surgeons to assist the surgery. And this is basically a surgeon's console. With the help of this surgeon console, surgeon operates from there and robotic arms moves. I will just show the pictures. And these are the equipments which are being used in a robotic surgery. The first one is the monopolar scissor, where you cut and incise. Second is a prografts. Third is a bipolar forceps. And the fourth is a monopolar bipolar Maryland forceps. Fifth is a needle driver, and sixth is a bipolar forceps. So let's dive into this small video where you can see how a robot generally works. So this is the robotic arm, and this is the surgeon console. So once the surgeon puts a head inside this console, then only the robotic arms get activated. So surgeon should sit and put his head rest on this arm, where he can see a 3D visions. And these are the telescopic movements, and left and right are the monopolar and bipolar cautery. So you can see in this video how surgeon operates with the help of a surgeon console. So you have to, it's just like a joystick. One had to put the fingers, and you have to do a maneuverability which can be seen in these robotic arms. So this is the patient, and the robotic arms are inside the patient, and surgeon is operating by sitting in the surgeon console. These are the movements where surgeon can sit easily and do surgeries without fatigue, more concentration, more 3D kind of vision, which may result in better outcomes. And this is the vision card where assistants help in assisting the surgeon. And this is the length of equipments which are used in surgery. Now we have seen in last picture what kind of equipments which we use. These are the magnified video. So with the help of these robotic techniques, a surgeon has been given a freedom of improved dexterability, means a freedom of movements of these instruments, which may help in better surgery, less surrounding injury, less blood loss, and better removal of the tumors or structures. Because of this precise surgical procedure, the outcomes and the functional outcomes can be improved. So what are the applications of robotic surgery in uro-oncology? Basically, for oncology perspective, these are mainly used in preserving a kidney, that is an organ preservation or nephron sparing surgery. Second would be like doing a radical prostatectomy, which is in robotic surgery we can have a better outcomes compared to laparoscopic or open surgeries, in form of preserving the continence of a patient and preserving the erectile functions of a patient. Third, it's like doing a reconstruction, when a major surgery like removing a bladder would instead helps in which means like you need to reconstruct a new bladder. The reconstruction can be done very easily with the help of robotics. So I'm just showing how a kidney saving surgery, that is nephron sparing surgery, can be done. On the right side, these are the pictures of a patient, very lean, thin female patient, where right side you can see a mass on the lower pole of a kidney. Okay, and this is the positions how patient given, and one assistant arm is for assistant. So this is the video. So once the robotic arms are inside, you can see how a picture is looking inside. This is basically a 2D image. Once you go through the 3D image by sitting in the surgical console, you will feel like as if you are sitting inside the abdomen of a patient and operating. On right side, once we go inside, we reflect the colon by dividing a peritoneum, and then we go enter into the retroperitoneal space. So since this patient is a very lean, thin patient, so after dividing this peritoneal reflection directly, we can see the IVC, and we are just dividing the peritoneum over the IVC. Once this peritoneum and medialization of colon has been done, we start then dissecting out the ureter. So in this picture, you can see once the lower pole is mobilized, you can see the peristaltic movement of the ureter. See if you can be seen very clearly. Once the ureter has been separated very easily, we lift up the lower pole of the kidney. Here it can be seen very clearly. Now once the lower pole has been freed completely, we move on to the renal hilar vessels. This is the renal vein. See how magnified it can be seen in this video. Once the renal vein is dissected completely free, we loop the renal vein, followed by we loop the renal artery. This is the looping of right renal vein and looping of right renal artery. Once this vessels has been looped, we clip the vessels. Now we start dissecting by marking the tumor. This is the lower polar tumor. You can see the kidney parenchyma very clearly, and the tumor mass hanging upside. Once the tumor is separated, dissected completely, we clamp the renal vessels, that is renal artery, and sometimes if required, renal vein. Now we start cutting the tumor. The plane is basically a bloodless. Why? Because we have clamped the renal artery. Now we are incising the tumor completely on every side circumferentially. This is dissecting out a tumor from the renal parenchyma. We keep on checking whether are we entering inside the tumor or not. We should generally, what we do, we take out a thin parenchyma of kidney so that we get a clear margin post surgical excisions. So once this is done, we bag the specimen and we take it out. Now the most important part is like reconstruction of the kidney parenchyma. So this is how we suture. The suturing, you can see how easily it is, like with the help of robotics. As if it's like doing with the help of, as if like we are doing an open surgery. This step is called as renography, where we close the defect of renal parenchyma. This is the last step of reconstruction, that is closing of the defect. Generally, we do all this job of removal within 30 minutes so that preserve the kidney function. So last step is bagging of the specimen and removing the specimen. So the main role of robotic surgery would be like in preserving the renal parenchyma or very advanced kidney tumor, that is stage 3 kidney tumor with IVC thrombectomy, and in major reconstructive surgeries of the kidney. So similarly in robotic prostatectomy, what we do mainly concentrate on patients' continence. Second would be like erectile function. If young male presented with early localized cancer, if he is sexually active, the patient concern first would be like preservation of his erectile function. These outcomes can be better achieved with the help of robotic program. This is a small video where you can see how a robotic surgery of prostate is been done. This is the prostatic normal location. In this surgery, basically, with the help of robot, we generally remove the entire prostate and seminal vesicles and part of vas deferens. These are small cuts which are given inside the abdomen, and this is how the robotic instruments move inside the abdominal cavity. This is how the surgeons move the joysticks in the simple term, and which can be similarly movements can be seen inside the abdomen. Along with the prostate, these are the seminal vesicles which are removed. If the stage of the tumors is high grade or high risk cancer or localized, we remove the lymph nodes. Once that is done, we do an anastomosis. This is the one of the most trickiest part of surgery, where a magnification, and within a small space of this, we generally do an anastomosis. So this is a hardly 30-second video where you can see how a robotic prostatectomy can be seen. It's just a part of a robotic prostatectomy steps. We are going posterior the prostate and dissecting the seminal vesicles and vas from the posteriorly. This is the right seminal vesicle, and right vas can be seen clearly. This is the left side vas. And this we are just above the rectal plane. So concluding, uro-oncology encompasses the diagnosis, staging and treatment of the cancer affecting basically of urinary system, which includes mostly the prostate cancer, bladder cancer and kidney cancer. So uro-oncology team generally involves a urologist, radiation oncologist and medical oncologist to achieve a better outcomes. So with the help of improved imaging techniques and biomarkers, we can give a better outcomes and functional outcomes to the patients. Thank you.
Hello. So I think cancer cases are increasing day by day, and presently we are moving towards a minimal invasive surgery.
Yes.
Definitely robotics has advantages, more precision, accuracy, lesser complication, lesser hospital stay.
Right.
And you have beautifully explained it in a very simple language. It was a very complicated topic, I feel, and the videos were beautiful. Yes. Thank you so much, Dr. Uday.
Thank you.
Thank you, sir, for a wonderful session. Recently, my mother was diagnosed with kidney cancer, and we did a robotic oncosurgery. So I completely agree with whatever he said, the minimal stay, minimum invasion, and a very good result. Thank you, sir. A big round of applause for Dr. Uday Chankhere, sir. I would request Chairperson Dr. Gajanan Dumbre, sir, and Dr. Neelam Kadam to please felicitate our speaker. Sir, please, Ms. Sanjay. Thank you, sir. And I would request Dr. Ashish Babil, sir, from Pimpre Gorav, to please felicitate our chairpersons. Dr. Ashish. Dr. Neelam Kadam and Dr. Gajanan Dumbre, sir. Thank you, sir.